In this course, we're going to be focusing on hip impingement, specifically hip impingement at the front of the hip, which is medically known as Femoroacetabular Impingement, or FAI for short. In 2016, a group of scientists published their definition of FAI. They defined it as a triad of symptoms, signs, and radiographic findings that we'll be looking at in more detail on this course. While I've mentioned this triad, we can quickly consider the main symptom would be pain in the front of the hip. And one of the key signs is pain here when performing this test called the FADIR test, and we'll have a look at this on the course. And the two main radiographic findings on X-ray are a cam shape variation, so the ball element of the joint, and a pincer shape variation on the edge of the socket part of the joint called the acetabulum. The cam is more likely in athletes and is associated with repetitive hip loading in maximal flexion during the adolescent years. Much less is known about the development of a pincer. Since the early 2000s, the number of patients being treated for FAI has risen sharply. Clinicians, funders, and healthcare systems are concerned about the rise in what was previously an unrecognised condition. The costs and uncertainties of treatment, the lack of clarity of the condition, and the ambiguity of the diagnostic criteria certainly add to the uncertainty and the lack of clarity surrounding this condition. Fortunately, there are many things that I'll show you on this course that we can do to help your patients or perhaps yourself. Now, these are the questions that we'll endeavour to answer on this online course. What is FAI syndrome? How should it be diagnosed? What is the appropriate treatment? What is the likely outcome if you have this condition? And what should somebody with no hip pain but an identified cam or pincer on X-ray, how should they be managed? Which outcome measures should we use to assess our treatment or our rehabilitation? And what to watch out for in future research? The hip is a ball and socket joint, but then again, so is the shoulder. So what's unique about the hip joint? Well, compared to the shoulder, the hip has a deeper socket, and this socket is made deeper by a rim of cartilage called a labrum, but you also have a labrum in your shoulder. The ball is held in the socket with negative pressure, so it's being sucked in, and its stability is aided by ligaments and controlled by strong muscles. This makes the hip joint much more stable than the shoulder, which it needs to be as it's a weight-bearing joint, and the shoulder is not usually a weight-bearing joint. You'll also appreciate that hips are not as flexible as shoulders in most people. When you flex the hip to end range flexion like this, it reaches its limit when the moving bones won't allow you to go any further, potentially causing an impingement on the front of the hip, but not yet pain. Pain may occur though for the following reasons. Regular bony impact may cause bone growth, leading to further impact and increased risk of damage to the fibrocartilage labrum. The hip joint may be forced into this end range by added weight or poor movement control. The joint may be irritated by lots of repetition or a continued position. And low levels of irritation would trigger an inflammatory response, which would heighten joint sensitivity and reduce the available pain-free range of motion. Pain then causes muscle inhibition and reduced motor control, leading to reduced control around the hip and pelvis, and this may simply present as reduced strength and reduced balance. Next, let's get familiar with some of the terms that are used to describe hip joint anatomy and joint shape. And for a moment, just broadening our view beyond FAI and looking at some of the other hip shape variations that can occur. The first one is coxa vara. This usually causes the knocked-knee presentation and is caused by the hip joint being more horizontal. This usually occurs in one leg following bony injury or Perthes disease to the hip. You would see a reduced femoral neck angle on X-ray and possibly a Trendelenburg gait pattern. The next one is coxa valga. This causes a more vertical hip joint appearance and is common in children with cerebral palsy. Femoral anteversion. This often causes in-toeing. This occurs before birth and can be related to fetal position. In order to place the hip in a neutral position, the lower leg then appears turned in. We call this in-toeing, or less kindly, pigeon toe. While this rotation can reduce by up to 50% between childhood and adulthood, this does not occur when conditions like cerebral palsy or Down syndrome are present. Children with in-toeing are often told to walk straight and to point their feet straight, which can often be painful and difficult to achieve. So avoid doing that or giving that recommendation. In cases where significant disability occurs, perhaps from frequent tripping, a femoral derotational osteotomy operation may be considered. Femoral retroversion presents when the toes point out. This is less common and less disabling than in-toeing. Again, you can assess for anteversion and retroversion using a simple range of motion test. See the Craig's test video as part of this course. Now, based on what we've just identified and discussed, I can recommend that when doing exercise, please allow for natural hip and foot alignment, which may be different on different sides of the body. And be careful not to try and force the patient, or in this case, perhaps your own leg, into any specific alignment, especially if it feels uncomfortable and unnatural. Of course, we will return to this point later in the course and look at it in a bit more detail. But on that note, also ensure comfortable positioning when preparing for and performing a massage. It's not always ideal to put the feet and the legs straight and in alignment if this is unnatural and uncomfortable for the client. So now that brings us on to the cam and the pincer, which are often referred to as deformities, but may be more correctly called morphologies, because they're often present without any symptoms. That is to say, you can have a cam, a pincer, or both without any hip pain. So they're not always the cause of the problem. Let's have a look at the cam. The cam is an aspherical shape on the femoral head that stops it gliding into the acetabulum socket and causes increased stress on the labrum cartilage rim. The presence of a cam is often measured from an alpha angle. Angles higher than 55 degrees have been associated with FAI. You can look for the alpha angle and perhaps ask about it when reviewing an X-ray. Next, the pincer. The pincer is a bony prominence on the front of the socket. Extra bone extends out over the normal rim of the socket, and the cartilage labrum can then be damaged underneath this pincer. Research indicates that hips with a cam are shallower and hips with a pincer have a deeper socket. FAI typically presents in young adults and is more common in athletes. Middle-aged to older individuals are also more likely to have FAI in combination with osteoarthritis, in which case the content of this course is still highly relevant and most likely to be significantly helpful. Lots of people without hip pain and who may never get hip pain have a cam or a pincer shape variation associated with FAI. It is therefore increasingly referred to as a morphology to steer the language away from suggesting a deformity is present. This small point of language is important because as soon as you tell somebody that their pain may be caused by a deformity, it will immediately increase their pain and greatly reduce the chances of recovery without surgical intervention. It is indeed the opposite of a placebo effect, which we call the nocebo effect. A nocebo makes people feel worse, and a placebo makes people feel better. Let's have a look at some research. A review of 26 individual scientific studies with a total of 2,114 non-painful asymptomatic hips identified a cam deformity in 37% of hips and a pincer deformity in 67% of hips. Remember, all of these people did not have any hip problems. Only 7 of the 26 studies reported on cartilage labral injury. Again, this is the prevalence in non-painful, non-symptomatic people. Therefore, if cam and pincers are common in people without hip pain or problems, the question is, should we receive surgery based on the fact that they have a cam or pincer, if that's often not the cause of the problem? Probably not. So based on the research, it makes sense to try simple activity modifications and exercise before sending patients with suspected FAI for surgical intervention simply because they had a cam or pincer identified on X-ray. In contrast to patients with no symptoms, the majority of patients with symptoms had a cam, pincer, or both on imaging. So it seems that if you have hip impingement, you're most likely to have a cam or a pincer. But if you have a cam or a pincer, it doesn't mean that you're likely to have hip impingement. But on this course, we'll look at what we should consider if we know somebody has that cam or pincer variation, but is not really having any hip problems. What should we do? What advice should we give them? And what exercises should they do or not do to help avoid future problems? That's a really interesting question and one which we'll cover on this course. So in terms of overall occurrence rates, femoroacetabular impingement, FAI, is suggested to occur in 47 to 74% of patients with hip pain and without arthritis. Especially in young patients presenting with hip pain, this seems to be the most common condition. FAI is a common and treatable condition that, if left alone, may lead to cartilage damage and early hip degeneration. The risk factors for FAI are abnormal morphology of the femur and or the acetabulum socket, abnormal contact between these two structures, especially vigorous motion that results in this abnormal contact, repetitive motion resulting in continuous or repetitive contact, and the presence of damage to the labral cartilage rim. In summary, remember that FAI is not diagnosed by an X-ray, but instead by three categories of presentation: the reported symptoms, clinical signs from testing, and of course the X-ray or other imaging findings. The course aims to clarify the current uncertainties surrounding hip impingement and provide strategies to manage femoroacetabular impingement effectively. Thanks for watching the introduction. Now it's time to move on to the next section. When it comes to the assessment, anterior groin pain, pain at the front of the groin, is the defining symptom of femoroacetabular impingement. And this can often be determined by the patient showing you by making this C sign, where they grab around their hip, hence making the C sign with their hand. And that's one of the key signs for femoroacetabular impingement. Without that, it's unlikely that you're dealing with this pathology. So pain in the front of the hip, pain in the front of the groin is a key symptom. Femoroacetabular impingement is associated with a reduced range of motion in the hips. So to check the range of motion, you could do the Faber's test, where you cross the foot over the opposite knee, stabilize the opposite side of the pelvis, and then let the knee drop out into this position. This is also called the 4 test, because if you look at the arrangement of the legs, it's making a number 4. So you can compare that on both sides to get a general idea of their hip range of motion. Normally the knee should drop out quite nicely as the hip opens up, but if there's less range of motion and the hip's stiff and won't drop down, that indicates a reduced range of motion overall. So these are the normative values for hip joint range of motion. Starting with flexion, you should be able to achieve 100 degrees. Make sure you bend the knee to take the hamstring tension out of the equation. For abduction, taking the leg away from the body, I'll show you on the opposite side so it's easier for you to see on the camera. Stabilize the pelvis, bring the leg out, and you should be able to achieve 40 degrees at least. For adduction, the opposite movements going across the body. Again, stabilize the pelvis, and here you should be able to achieve 20 degrees. For internal rotation, you should be able to achieve 40 degrees, and on this model you can see that internal rotation is a little bit restricted. For external rotation, that's usually a lot easier, and that should be at least 50 degrees. Next, we'll look at hyperextension of the hip. So support the leg, stabilize the pelvis, and lift the hip up. Here you should be able to achieve 30 degrees at least. Make sure you stabilize the pelvis and make a note if the pelvis starts to lift, that's the end of the hip range of motion, and all you'll be doing is simply lifting the pelvis or seeing the spine twist. So stabilize, and as soon as you start to feel that pelvis move or rock or twist, that's the end of the range of motion. Also, keep the knee fairly straight. If you bend the knee too much and try and lift like this, you've tightened up the rectus femoris, you've tightened up the hip flexor, and therefore that will cause a restriction in the range of motion. For FAI, the most specific movement restriction is flexion, adduction, and internal rotation. And we can do this as a test known as the FADIR test, and I'll show you how to do that in just a second, but as you can see, it's a very simple movement combination. Now, the FADIR test is a very sensitive test, so that if they do have FAI and they have that anterior groin pain, then it's almost 100% likely that the FADIR test will cause the reproduction of the anterior hip pain. However, it's not a very specific test, so that means there are lots of other things that could cause pain in the front of the hip when you do this test, such as labral injuries and, well, osteoarthritis as well, for example. So that makes it a very sensitive test that will be positive if the condition is there, but not very specific because there's lots of other reasons that test might be positive. So its clinical usefulness is somewhat questionable. However, it is still the most commonly used test when assessing femoroacetabular impingement. And there is not yet a better clinical test to do. So that's still the main test that people do when assessing for this condition. Let me show you how to do the test. So flexion up to around 90 degrees. Adduction, push the knee across to the opposite side of the pelvis, and then at the same time or after that, add in internal rotation. So flexion, a cross-body adduction, and internal rotation. Okay? When you do that, you can see that you're closing the hip. You're closing off that inner groin. So if there was a cam or pincer morphology, then this would be causing that abutment of those bony prominences against each other, or of course against the cartilaginous labrum rim. So that's the FADIR test, and as you can see, the FADIR stands for the movements that you're doing: flexion, adduction, internal rotation. So showing you the FADIR test on the other side, up into 90 degrees of flexion, and then a cross-body adduction and internal rotation, achieved by pushing the foot out and rotating the knee in. The next test I'm going to show you is called the Dremond's sign. It is primarily used to check for a slipped capital femoral epiphysis, but it can also be used to help you assess for FAI. Here's what you do. We're looking at what happens to the hip when we flex the hip without forcing it to stay in a straight line. So bend the knee, but primarily hold the foot. Let go of the knee and then push the knee up towards the chest. Now, in a normal hip, there'll be no reason why the hip can't flex up past 90 degrees towards the shoulder, okay? With a hip that has some pathology, such as the slipped epiphysis, or of course, some bony abutment of a cam or a pincer morphology, then it won't like going up into flexion, and as a result, the hip will come out to the side in order to flex further. So quite simply, normal, you push and the hip goes up towards the shoulder, and a positive Dremond sign is the hip comes out to the side when you flex the hip up. If it does, it indicates that the hip does not like flexion and is not comfortable or able to go into that level of flexion, and it could be another positive sign of pathology, possibly femoroacetabular impingement. Hip pain in children. So far we've mentioned two conditions that may cause hip pain in the young patient. Overall, hip pain in children is rare, and therefore any child presenting with hip pain should be referred for further tests, including imaging, because early detection, management and intervention is key to avoiding unnecessary future problems and procedures. Femoroacetabular impingement cannot be diagnosed without evidence of a cam or pincer morphology on X-ray. But remember, as discussed earlier, the presence of these anatomical variations, the cam and pincer, does not guarantee that FAI is the cause of the pain. However, if these are present in addition to the reported symptoms and the FADIR test is positive, then the triangulation of these results make FAI, femoroacetabular impingement, the most likely diagnosis in the absence of osteoarthritis. When you refer a patient for an X-ray or make a polite request to the doctor with your suggested diagnosis, it's important to make sure that the X-ray team know what they are looking for before they take the X-ray, and then they can decide which X-ray views would be best. So radiological assessment is best achieved initially with plain radiographs. A pelvic radiograph allows an overall assessment of the pelvis and hips, and the exclusion, therefore, of other painful conditions such as a fracture, acetabular dysplasia, and osteoarthritis. Following the X-ray, there may be a need for CT scans or MRI to assess the anatomy more precisely. A very important part of the assessment is to learn from the patient which movements and activities are associated with the pain and symptom aggravation. You will, of course, have a good idea that it is most likely some repetitive loaded or sustained hip flexion would probably bring on their pain. But it may take some conversation to pick out the particular actions and activities which are causing them the symptoms. There may sometimes be a delay between the activity and the increase in hip pain. So take some time to understand what the patient is doing and any new activities that they may have recently started to participate in. A big part of the non-surgical management of femoroacetabular impingement is activity modification. So we first need to understand the activities before we can plan to modify them. In addition, you want to assess the patient's gait, that is their walking pattern. Are they walking with a hip dip, a Trendelenburg gait, or perhaps with a shorter stride length due to a lack of hip extension? You would hope to rectify this by reducing their pain and increasing their hip strength. It also pays to assess more functional tests such as one-leg balance. Check the one-leg balance on both sides, and you may notice that on the symptomatic side the balance is not so good and there seems to be a bit more of a challenge to maintain balance on that leg, indicating not just a loss of balance, but a loss of muscular strength and motor control around the hip as well, which would be most likely if they've had the FAI symptoms for some time. You can also use some simple Pilates exercises to check for the strength and control of the muscles around the hip joint. For example, with the bridge here, you can start with a bridge, bilateral one using both legs, looking to see if there's any difficulty on one side, which would be shown with any asymmetry when performing the bridge exercise. But it's better if you can get your client to do a one-legged bridge, starting on the non-symptomatic side to begin with. And here you can look at the quality of the movement, the range of motion, and ask the patient about the reported difficulty performing the test, comparing it to the symptomatic side, where you probably would see some differences in the ability to perform the test. So again, the quality of the movement, which you can see, the range of motion, which you can see, and the reported difficulty in performing the test, which you could possibly see, but you want to ask about and ask the patient about. They might say it's more difficult, it's harder to control, and of course they may say that there's some pain there as well. All of these things are important to assess and make a note of, and of course you'll be looking to improve them with your advice and with your rehabilitation and activity modifications. The next exercise, if you turn onto your side please, Richard, is the clam. When performing the clam, make sure that you have the patient slightly move forwards, and that's important because if they rock back, then they can lift the leg up really high and it activates different muscles in the hip. So have them slightly rock forwards and maintain that position as they then lift the knee for the classic Pilates clam. Again, looking for the quality of the movement, the range of motion, and the reported difficulty. And of course, comparing both sides with this exercise as well. The next exercise you can look at is the standing hip abduction. Of course, you're looking at the leg which is being moved out into abduction, but also the stabilizing leg is also having to work hard as well. So compare both sides. There may be difficulty in abducting the symptomatic leg, and there may be difficulty stabilizing on this symptomatic leg as well. But make a note of what you see, and then you've got something which you can work on and try and improve on with your rehabilitation. Hip impingement part 3, activity modification. We need to avoid anything that closes the hip. So when it comes to sitting, the classic aggravators are low chairs and sitting with the legs crossed. Educate your patients to raise the seat whenever possible. And to move the hip from a closed position to an open position if they do need to sit in relatively low chairs. Because repetition is often a factor, when it comes to aggravating postures and positions, these are usually linked to occupational tasks where the individual may be required to repeat the movement in order to perform their job. This could be bending to pick things up or crouching down to low positions, which I commonly see in patients that work with young children or in the building trade, like electricians and plumbers, for example. So how can somebody get down closer to the floor if they're working as an electrician or working with young children, or if they need to often pick things up? Well, here are some simple activity modifications that you or they can do instead of squatting down and flexing the hip. Drop down into a lunge position so that you can place the symptomatic hip on the straight side and keep your hip out with some abduction and external rotation on your non-symptomatic side. So therefore the painful side, the hip is not being flexed as much or routinely if you drop down into this position, and the other hip is still turned out into external rotation. So hopefully that should make things a lot more comfortable if you make that your habitual movement when you need to crouch down. Another alternative is to use a kneeling cushion. Have a few of these around where you're likely to need them. Therefore, you can go down into this position onto your knees rather than down into this deep squat position. Once again, making it more comfortable on your hip. Fitting shoes. Some simple changes to the fitting of shoes can also help if this is a problem and if it's an aggravating factor. Quite simply loosen the laces or use Velcro, open the hips like so, and use a shoehorn. Next, we'll look at exercise habits. Let's look at deadlifts, squats, and then we'll look at cycling. So you may be causing femoroacetabular impingement by something that you're doing, a certain movement, particularly one with repetition that involves lots of hip flexion. Like the deadlift, for example. So let's have a look at this exercise first. The first thing to look at with the deadlift is when you flex down to the bar, you may be flexing down too low or to a point which is causing the hip irritation. So there's a few simple things you can do so that you don't need to flex so far down to get to the bar. The first one is the weight plates. If you put the larger size weight plates, not necessarily heavier, just the larger size weight plates on like we've done here, then that means the bar is higher, therefore you won't need to go so low to get to the bar. The next thing is you'll see Richard here. If you come back up again, Richard, you're going to get fatigue in your quads doing that. You'll notice he doesn't have any shoes on. Now, whether or not you wear shoes to do the deadlifts is another thing that we can debate, but by removing your footwear, and go down again, by removing your footwear, you effectively get lower under the bar, and it means the bar comes up closer to you as well. Because obviously if you have shoes on, or if you imagine standing on a platform, the bar would be relatively lower. So simply removing your shoes is the same as slightly lifting the bar. And then down. And the next thing is to put something underneath the weights, again, to have the bar up a little bit higher. What could you put under? Well, you could put some additional weight plates underneath each of the weight plates there, or you could often find some rubber mats in the gym that you can put one or two underneath, effectively lifting the bar up a little bit so you don't need to drop so low. Or you could use the squat rack or squat cage, put one of the bars in there, and then do the deadlifts from there. Now, there's some other things you can do. Let me tell you what they are. The first one is to allow more clearance through the hips, widen the stance. So Richard's going to have a wider stance, possibly moving towards a sumo stance here. He's going to slightly externally rotate as well by turning his feet out. And then it's probably not going to be so easy to reach the outside of the bar. So he's going to hold central on the bar with a wider stance. Great. And then down. Let's see if we can improve on that a little bit further. Richard, I want to go even wider. Nice wide stance. Great, and lifting from there. Brilliant. Remember, the FADIR test is when the hip is flexed and adducted and internally rotated. And then come down, Richard. However, here, the hip's flexed, but it's abducted and externally rotated. So it's providing more clearance on that inner hip, hopefully allowing you to do this exercise or something similar to that if you're doing something more functional, such as reaching down to pick up something off the floor, such as shopping or some heavy objects at home, for example. This would be the preferred movement. So if we look at what not to do, that's standing with the feet close together and maybe standing with the feet together just to over-exaggerate, and then flexing down. So this would be what not to do, which is where the hips are turned in, there's loads of hip flexion there. That's what not to do. That probably would more than likely cause aggravation of a hip impingement issue. And what to do is have that wider stance, opening the hips, abduction, bit of external rotation, provide some more clearance through the hip joint, and that will allow you to do the exercise or the functional movement a lot more comfortably. And then back down again. We're just doing a demonstration here, but don't forget to put your clips on the bar so that the weight plates don't start to slide off. It's a small safety thing that we often get told to do in the gym. Now, there's a few other things we can do, so have a look at that. We're going to turn to the side now and have a look at the pelvis movement, because that's also important. Pelvic control and awareness of pelvic position is also important when you're doing these exercises, and that's because the hip position is not just dictated by the position of the thigh, the position of the femur, it's also dictated by what's going on at the pelvis, typically whether it's anteriorly rotated or posteriorly rotated. So if we get Richard to do a lift here, to go down into a squat and a deadlift position, we can see that if he posteriorly rotates his pelvis, that will flex his lumbar spine. That actually reduces hip flexion. It might not be ideal from a lifting point of view, and there is debate about whether you lift with a neutral spine or a curved spine, but that's not all what we're getting at here. We're thinking about hip position and reducing the symptoms. So posterior tilt reduces the chance of impingement and puts the hips into a less flexed position. So in contrast, if he goes down with a hyperextension, hyperlordotic lumbar spine, that will anteriorly tilt his pelvis and close off the front of the hip, effectively increasing hip flexion, especially in the deeper part of the movement. So arguably, it might be best to make sure that the lumbopelvic control puts the spine into a neutral position, rather than one of hyperextension or excessive flexion. However, if there are lots of symptoms and somebody does need to go and pick something up on a more functional basis rather than as an exercise, then bending down with a flexed spine will reduce the need to flex the hip as much, especially in the deeper part of the movement. So lumbopelvic control is important, and we will return back to that when we do the exercises and the Pilates session. We'll work on lumbopelvic control. Not just because it makes sense from a biomechanical point of view, but also because the research shows that if you can improve lumbopelvic control, it can help to reduce the symptoms of femoroacetabular impingement. So it is a very evidence-based approach. So just to recap, if you go down into that deadlift position with a curve in the spine and a posterior tilt, that reduces hip flexion and probably reduces the symptoms. If you have the opposite, anterior tilt and an excessive lumbar extension, that will probably make the symptoms worse, as it's required to flex the hip more. So neutral, possibly flexed, they're the best positions to go down and lift from. So to conclude, adjusting the lumbo-pelvic position may help you to get down into those squat and deadlift positions without triggering off the pain, irritation, and an inflammatory response from the joint. Next, we'll look at squats. Whether it's weighted squats in the gym or whether it's body weight squats at home or as part of an exercise class, modifying the squats and having an awareness of what to do and what to avoid can be really helpful for reducing the symptoms of FAI. So the first thing is, when you're doing the squats, you don't have to go all the way down. You can just do half squats or work out a range which is comfortable for you. So although people might be dropping down further or encouraging you to try and get your bum down towards the floor and to do full depth squats, that may not be possible for you. Your hip joint anatomy may not allow that. And if you do try and force yourself to do it, it's likely to cause some unnecessary pain. You'll still get brilliant strength gains from doing half range squats versus deeper squats, and you'll get so much better strength gains than not doing them at all. Also remember what we talked about with the deadlifts, having a wider stance, a bit of external rotation. That can also help to improve the comfort of the squat and possibly allow you to go down a little bit further. But don't worry about how far down you go, don't make that your aim. Just do your squats in a comfortable range, do your repetitions, get some muscle fatigue and adaptation, and you'll still get some brilliant fitness benefits. Next, we'll look at the lunge exercise. The lunge exercise is a brilliant exercise. We're going to look at how you can incorporate this into your exercise routine, but also how you can use this movement to get down low and to get down to the floor and avoid aggravation of your hip. But here is something that you should avoid. If you're in the lunge position and you're going into a stretch, so here on Richard's hip on the left side closest to you, the front of the hip is stretching. You need to be careful with that action, because if there's irritation on the front of the hip, then this is likely to pull and cause some discomfort. So be careful you don't hyperextend the hip when stretching and doing lunge exercises, because that is a common movement that can cause aggravation of femoroacetabular impingement. I know it's the opposite movement to flexion, which causes that joint squashing, but here we may have some stress going on around the joint capsule and the labrum, and also a bit of anterior glide of the glenohumeral joint as well. And those things, or one of those things, is thought to contribute to anterior hip pain. So lunges, brilliant, just don't overstretch the front of the hip. The next thing to consider here is fatigue. If you've got your exercises working well for you and you've got good form and you've adapted your technique, fatigue can sometimes throw that out the window, can sometimes make you forget about that and start to do more problematic, more aberrant movements. So with a squat, for example, if you get too fatigued, you might start to drop down a bit too low. The legs might start to move into internal rotation a little bit. I'm going to talk about the lunge a couple of times on this course. From my personal experience, I found that switching from squats to lunges was more comfortable and less irritating on the hip. Next, we're going to look at the bicycle, whether it's outside or inside, because cycling, particularly a stationary bike, is one of the key things for hip rehabilitation, and that often starts very early if you have had any hip procedures. So cycling can be fantastic for the hips as well as for overall health benefits. But there's a few things to watch out for, a few things that you need to get right. And the first and perhaps the most important one is the saddle height. If the saddle is too low, yes, you can get on the bike easier, but if the saddle is too low, as you can appreciate, the hip will be too flexed at the top of the movement, and that can cause unnecessary hip irritation. So to set the right saddle height, ideally at the bottom of the pedal stroke, you want the knee to be slightly bent. So Richard, if you pedal backwards here so we can have a look. So the bottom of the pedal stroke is where the leg is at the straightest point. That's here. You can see that the knee is slightly bent. Therefore, if Richard pushes his heel down, the knee will straighten. But with the heel in a more flat neutral position, the knee is slightly bent. If he puts his heel on the pedal, then that would also put his leg into a straight position. So that indicates that we've got the right saddle height, because he can perform a pedal revolution there. His knee never fully straightens or locks out, but the legs get into a fairly straight position at the bottom of the pedal stroke, thus reducing the hip flexion. The next thing to consider is what's going on at the upper body. We've put Richard here on a mountain bike with a fairly short reach between the saddle and the handlebars, and also a fairly upright position, which is common on most mountain bikes. If he was down on a racing bike in this sort of position, straight away the movement of the upper torso puts that hip into a lot more flexion at the top of the pedal stroke. So if you come back up again, please, Richard. So make sure the upper body is more upright, perhaps as upright as possible when you first get started, and choose a type of bike which will help you to achieve that. Make sure the saddle is at the right height, and those two things should help you to cycle comfortably without irritation, and then to get lots of the benefits of hip strengthening, lower limb strengthening, and general cardiovascular conditioning. Hello and welcome to the hip strengthening and Pilates section of this course. The research shows that if you can improve lumbopelvic control, perhaps otherwise known as core stability, that can help to alleviate symptoms of hip pain, including femoroacetabular impingement. And the research also shows, perhaps unsurprisingly, that people with FAI also have reduced hip strength, and especially in the adductor muscles, those ones on the inner side of the thigh. So we'll have a look at strengthening those adductor muscles as well. We're going to start off with some Pilates. Pilates comes from a chap called Joseph Pilates, and it was originally called controlology, which is helpful because it's about the control of the movements and the mind to muscle connection and getting that coordination back into some of those muscles which may have lost that coordination due to pain, dysfunction and disuse. So it's not about repetitions or how high or how far you can push each exercise. It's about how well you can control the exercise. And Pilates is really good for working on lumbopelvic control, which, as I mentioned, can reduce the symptoms of hip pain. Let's get started. So I recommend you lie on a firm surface, but have something like an exercise mat so that you're comfortable. Unless you're lying on the carpet, that may be comfortable enough. I'm here on my Stabil 7-section Pro couch, which is intentional so that it's raised up and it's better to demonstrate for you on the camera. Nonetheless, make sure you're comfortable, and you may want a small pillow under your head as well. We're going to start off with some setting exercises, because remember, Pilates is not about thrusting and throwing and lifting and counting repetitions. It's about control. So start by lying in this position. Knees up, feet flat. And first off, let's pay attention to our pelvis. I want you to tilt the pelvis towards you. If you look at my hands there on the side of my pelvis, tilt the pelvis this way. Tilt the pelvis towards you. That will flatten your spine and slightly lift your bum off the floor. And then relax and go the other way. This will arch your back, okay, and push your bottom down into the floor or mat. Next, think about the rib cage. We're going to come back to the core area in a moment, but first of all, the rib cage. Make sure your rib cage is not flared and sticking up, and just make sure you flatten your rib cage by flattening the midsection of your back. Shoulders back and down, and then relax. They shouldn't be up here. Back and down and relax. You don't want your chin on your chest, and you also don't want your head sticking up too far. And with your pillow, guys, make sure your pillow is not too big and causing your neck to flex like so. The best thing to do with no pillow or a thin pillow is lengthen the back of your neck. So place your thumb at the base of your neck and your fingers at the top of your neck, and just slightly nod your chin. Don't flex your whole neck, just nod your chin so it's upper cervical flexion, and lengthen the back of your neck. Try that without the pillow as well. You might find that a bit easier to achieve. I'm going to proceed there without my pillow, which seems to have dropped off the top of the couch. There's a couple more things to think about, and these are perhaps the most important, which is why I save them to last. Breathing. Place one hand over your abdomen and one hand over your chest. Breathing should be relaxed. Unless the individual has a breathing issue or disorder, then this position should be fine. If people have a breathing disorder, you may need to adapt these exercises in the seated position. The abdomen should rise and fall with relaxed breathing, and the chest should stay still. If there's lots of chest movement, then it indicates that they're not breathing as efficiently as they could be, or perhaps they have a breathing condition. So just relax and focus on diaphragmatic, also known as abdominal breathing, which is indicated by the gentle rise and fall of the abdomen and a relaxed chest. So you may want to spend a few moments just working on relaxed breathing. After that, we want to activate the transverse abdominis, which is a flat muscle across the abdomen, and it's part of our pelvic floor musculature. So there's 3 ways to activate that. Number 1, imagine you're in a queue for the loo and you need to hold it because there's a queue and you have to hold and contract your bladder. So do that and contract those bladder muscles. Don't hold your breath. And in doing that, you should get a flattening across your lower abdomen, as well as a feeling of a general tightening and drawing in of those pelvic floor muscles which are on the floor of your pelvis. So hold that for a few seconds and relax. That's how you activate your pelvic floor, including your transverse abdominis. That's the first way. The second way is to imagine that you're tightening up a belt. A bit odd that you tighten a belt lying down, but bear with me. Imagine you're tightening up a belt on your trousers, and as you do that, you want to hold and flatten your lower abdomen so that you can do the belt up nice and tight, or as tight as you'd like it to go. So imagine that, literally just imagine you've got a belt in your hand, tighten it across your abdomen and tighten up those lower abdominal transverse abdominis muscles. And the third way is to push down on something, which you can do kneeling, but we're in this position. So have your knees up and just gently push against your knees without letting your back arch, and that will tighten up across your lower abdominal muscles, but also cause a general tightening in your larger rectus abdominis as well. So it's better to start with the imagine you're in the queue for the loo technique, okay, and then the belt, and then if necessary, pushing down on your knees, which you can also do from a kneeling position on a chair as well. Okay, so they're the 3 ways. That's it for now. We're in the setting position, we're ready to go. I would recommend with your clients you spend a bit of time doing that. The last thing you want them to do is to be flailing around and throwing limbs all over the place without any idea of control. So just to spend a few minutes getting them used to that and controlling the exercises. For our first exercise, we're going to look at pelvic tilt. Very simple but very helpful Pilates exercise for gaining control around the lumbo-pelvic region. So in our position, make sure we do our setting exercises with our pelvis, breathing, shoulders. And what I want you to do now is to tighten your abdominals, flatten your lower back towards the floor, tighten up your glutes and tilt your pelvis towards you. Okay? So you're flattening your spine and tilting the pelvis. I often like to think of flattening the spine and tilting the wine, assuming you've got some wine that's tilting towards you. If you don't like wine, that's fine. I know that rhymes. Tilt the water, orange juice, beer. So flatten the spine and tilt the pelvis towards you. We're not yet lifting off. This would be a bridge action. We'll get to that later. We're just tilting the pelvis. And when you're doing that, you should naturally be tightening up the pelvic floor muscles, including the transverse abdominis. But what we're also doing here is we are extending the hip joint, because as we tilt the pelvis, it's bringing the hip into a degree of extension. And this is a key point here. When it comes to hip movement, it's not always about what the leg's doing, it can be about what the pelvis is doing. Now I want you to practice the pelvic tilt in 3 different positions. Position number 2, in a seated position, tilt the pelvis in both directions. So anterior tilt, posterior tilt. Okay, stick your bum out and tuck your bum in. Just turn to the side there, so anterior tilt, posterior tilt. Finally, perform that exercise in a standing position. In terms of how many to do, that's a difficult one to answer, but it would be reasonable to do 10 of each, or perhaps go for 30 seconds of each. Remember, it's not about counting the reps, it's about the quality of the movement. So I would prefer to time it and do 30 seconds of each, but with the focus being on control rather than watching the clock and seeing whether 30 seconds yet has been achieved. So focus on the quality rather than worrying about how many or for how long you're doing them, and make sure that that is the focus. The next exercise we're going to do is the one leg fall out. This is a very simple exercise in its movement, but it is about the control. So make sure you're in a comfortable starting position and get the pelvis into neutral. All you need to do is let one knee drop out, so abduct to the side, under control, and back in. When you do that, it's important not to let the body rock and the pelvis lose control. So keep the pelvis stable, keep the other leg stable, and let that leg drop out to the side and back in. Then repeat on the other side, leg out and back in. Now, if you don't have any hip issues and you're relatively fit and strong, you will be doing this exercise to practice and in preparation for showing your clients and thinking that it is very, very easy. However, remember, if somebody has hip pain, this exercise is likely to be difficult. It shouldn't be painful. There's probably going to be a lot of holding and guarding of the hip joint. So therefore, just releasing and letting the hip come out to the side may be difficult for them to achieve. And also with pain, there's often a loss of motor control. So it's likely that they will struggle with allowing and coordinating this exercise. The next one is called scissors. All you need to do from that starting position is lift one leg up and down, then the other leg up and down. There's different levels to the scissors, but for this course, for rehabilitating hips, we're just going to stick with this nice, easy level 1. Now, remember, when you lift, you've got to control the pelvis. The last thing you want is an arching of the back. So neutralize the pelvis, keep the tension, lift and down, lift and down. Bring the thigh so that it's at 90 degrees to the floor, as long as that's comfortable. If that causes discomfort, then don't lift so far, or bring the thigh out to the side and down. If you want to know how many reps or sets to do with that one, I'd recommend doing it until they start to feel a moderate level of fatigue in their abdominal muscles, and then stop, take a rest for 1 to 2 minutes, perhaps do some of the other exercises we're about to go through, and then come back and give it a go another 2 or 3 times. The next 2 exercises are abdominal exercises. Number 1, the simple abdo curl. Arms come down by the side, just slightly off the floor. Head comes up, and all we need to do is an abdominal crunch and down. It won't give everybody an instant six-pack, but it will help to build lumbopelvic control. However, be careful that your clients don't overdo it, because the abdo work is just a part of the strengthening, and sometimes people have a habit of trying to overdo abdominal work in the hope of getting extra strong tummy muscles or a six-pack, as I mentioned. So include that in your routine, but just make sure they don't do too much of those. We also want to do the obliques as well. Twist and back. And simply repeat that until they start to feel some fatigue in their obliques or general abdominal muscles. Now we're moving on to one of my favorite exercise routines for strengthening the hip. If you have some equipment available, I'd recommend something to squeeze between your knees, which could just be a cushion, a foam roller or a ball. I've got here a foam ball from Trigger Point, and I've also got an exercise band here. Fairly low strength. You can choose ones with different resistance levels, but have a look at what we're going to do with it first, and then you can determine what's best. If you don't have one of these smaller loop bands, then a larger exercise band will do. You can just shorten it and tie it off. And if you don't have an exercise band available, then perhaps you could just put a belt around your knees or a strap around the knees to push out against. Start by lying on your back in that starting position. If you have a ball or a cushion, place that between your knees and gently squeeze it to activate through your adductors. Tilt the pelvis by flattening the spine and tensing up your buttock muscles and also across your lower abdomen as well. Lift your bum and lower back off the floor so that your spine starts to come into alignment with your thighs. Just go up as far as is comfortable, and it's not a case of the further the better, so you don't need to try and go right up into this position where quite simply your spine would be hyperextended, and that's not so helpful at this stage. Once again, tilt the pelvis and lift the lower back and bottom off the floor. Hands stay down to stabilize your body. And as you come down, roll your spine down and then relax the pelvis so it goes back into neutral. For the first variation, take the ball away, tilt the pelvis and lift up into that standard bridge position. Then let one side of your hips relax by relaxing the glutes, and the pelvis should then twist, in this case slightly towards you. Reactivate the glute to lift the hip back up, relax the opposite glute, and now the pelvis should twist away from you in this case. Reactivate the glute to put the pelvis back into that level position. Relax the left and back. Relax the right and back. Relax the left and back. For the next exercise, we're going to work on the abductors here, so more of the glutes in this case. And this is where we're going to use our resistance band or belt, whatever you've got available. So pop that around your legs. Okay, now the belt is pulling your knees in, so you need to pull the belt out slightly so there's a small gap between your knees and your thighs are roughly in line, roughly parallel. Tilt the pelvis and lift up into that bridge position. From here, push out against the band or belt. If you've got a non-stretchy belt that you're using, you'll just have to push out against that and do an isometric contraction. But if you've got a more dynamic band, then you will be able to go out into some abduction, squeezing those glutes, feeling some different muscles activating, and back into neutral. So you can mix these exercises together. For example, you can do the pelvic tilts. Okay, and when you're ready, you can pelvic tilt up into a bridge. You could do a one-sided abduction, one side at a time, or both sides together, and then back down and repeat pelvic tilt, lift into the bridge and abduction. Back to neutral and lower back down. Now the final part of this routine is the one leg bridge. If you remember, we also did this during the assessment to assess for any strength discrepancies between both sides, which of course you would expect if somebody had symptoms on one side. To do the one leg bridge, lift one foot off the floor and then do your pelvic tilt and lift into a bridge. This is a much harder exercise and you won't be able to get as far up into the movement, but it's definitely worth doing. And remember, in the assessment we did it for comparison. So even though I don't have any specific hip issues, I can certainly feel that on my dominant leg, my right side, the exercise is easier to achieve and I can probably lift a bit higher. So when you have a go, see how it feels for you. Pelvic tilt and lift. So when you're teaching the one leg bridge for FAI, if they can perform it on the symptomatic side, even to a lesser degree than the non-symptomatic side, then it will probably be a very good rehabilitation exercise for them to do. and they should try and improve the strength and control of the movement, which may take a few weeks of regular exercise, but then you should be able to see a closer match between the symptomatic and non-symptomatic side. So lie on your side in a comfortable position. Now it's an option to do the clam level 1 exercise, but I'm not a fan of this exercise for FAI. However, it's worth showing you so that you've got it as an option, and it also helps lead us into the level 2, which is the one I want you to do. So lying on the side, the common mistake with the clam is that people rock back and then lift their leg up too far. And that doesn't work so well and doesn't target the muscles in the way that we would like. So rock forwards, I'm rocking towards you, and my upper knee is coming over my lower knee, which is just indicative of the fact that I am rocking towards you. Then I'll stabilize the pelvis with my hand here so I know what it's doing. I'm making sure that I'm not rocking back as I do the exercise. Feet stay together, and we just lift the upper knee away from the lower knee. And because I've rocked forwards, the knee won't be able to lift very far. Level 2 is the one that I want you to do whenever possible with your FAI clients. Lift up into the clam and then let the foot come away as well. Now imagine that foot is stuck on the wall. Try and keep the foot still and perform the clam from that position. External rotation, lowering down into internal rotation. External rotation, lowering down into internal rotation. It's really working on the finite control of that small range of hip motion. And very quickly, for most people, you'll find that you get a significant level of fatigue in those deeper gluteal muscles. The next exercise is hip circles. Again, it's about control. Straighten the leg, make sure you stay on your side, abduct, and then perform small circles. Imagine you've got a pen between your toes and you're trying to draw circles on the wall or window below your foot. And add some variety by creating bigger circles and smaller circles. You can even make it a bit of fun by trying to write your name as you're doing the exercise. It's just about the control. Once again, very quickly, you'll feel those deeper gluteal muscles working very hard. The next exercise is entirely different. This is for the inner thigh muscles, the adductor muscles. Straighten the lower leg, place the other foot in front, and you want that lower leg to lift off the couch. Okay, you can see that there. Just a small range of motion, lift off the couch. I'm going to move this front leg out of the way so you can see a little bit easier. So this leg here, lift and down. Lift and down. And that is the beginnings of some adductor strengthening, which we're going to build upon later in this video. Moving on to our front into the prone position. Here we can start to work on the hip extensors. So we're going to go into this swimming position, and we can start off with some leg kicks. So the leg stays straight and we extend from the hip by tensing up our glutes, working on alternate sides. You can then bring in the arms, raising the arms up and down, and then an alternate lift. As we've been doing with all of these Pilates exercises, there needs to be a good degree of control and no breath holding. So we're not doing this flailing around movement. We're not seeing how far we can go into the exercise. It's all about control, mind to muscle connection, and just restoring that motor control to areas that may have lost some of their coordination as well as strength due to pain, disuse, and often a fear of movement as well. A more advanced version of that exercise that involves a bit more balance and control is the bird dog or the quadruped. Coming up onto all fours, we can start with just the legs, bringing one leg out into extension, making sure that the spine and the leg are in alignment and we're not arching like so, and back in. Back to the other side, and back. Then bringing in the arms, alternate sides, which I actually find is a little bit easier because the arms can help to balance you as you perform the movement. And this is an excellent exercise for working on many things, including strength, coordination, and balance. Another variation of that exercise, it doesn't look that glamorous, but it's a good one to do. Take one leg out, so abducting to the side and back in. And then taking it out and combining that with a hip extension and back in. So abduction, extension, and back. Can we do that with the arms as well? Abduction, extension, and back. Other side, abduction, extension, and back. Not only does that work some different muscles, but it's also a bit more of a balance and coordination challenge, which can be perfect for a bit of progression with your clients. Now we'll move on to some standing exercises, starting with this side lunge abduction exercise. So stand in a nice wide stance and then externally rotate your legs so your feet are pointing out. So you're in this kind of plie position. I know I don't look like a ballet dancer right now, but bear with me. Then take your weight from side to side, so you're loading left, loading the right, loading the left. Then go across to one side, fully load that leg so that you can then take the weight off the other leg to perform an abduction exercise. Controlling the abduction, coming down to the floor, but just a toe touch, so you're not resting, just touching the toe. And after a few repetitions, you'll feel some fatigue in your glutes, if not in the stabilizing leg. So after a moderate level of fatigue builds up, leg down, transfer to the other side, take the weight, and then abduct like so. The next exercise is a classic one that you've probably seen. We'll get our resistance band again, pop that around the bottom of the thighs just above the knees, and this is the crab exercise. So you can crab walk to the side, that's a nice routine to do, or you can stay in one position and do your abduction to the side, similar to what we were doing, but with the added resistance. Or you can do a combination of both of those. So crab walk, abduct, crab walk, abduct. And finally, if you want something different or if those exercises aren't suitable, then you can do this simple exercise called the gate openers, standing on one leg, flex the hip, abduct the hip to the side, straighten the knee and back down. Okay, flex, abduct and out. Flex, abduct and out. This is also good for helping to improve one leg balance. I also find it helpful to use a step for hip strengthening and rehabilitation because it can be very functional and helpful in the patient's day-to-day life. So here's what you do. You stand on the step side on and you simply lower the other leg down to the floor and back up again under control, making sure that it's not a drop down and that it's a controlled lower down. Then we can make some modifications to the movement. Most of the time people will use their knee a lot to perform the movement. What we want to do for rehab though is actually get them to lean back, take more weight through their heel, and therefore start to put more load through their glutes. So by sticking their bum out, taking the weight through their heel and lowering down, it brings in the glutes a lot more for that exercise. Bit of balance involved, so if they're wobbling a bit, then make sure they can use something for balance initially. Sticking the bum out, weight through the heel and back. When you try that, you'll feel there's a lot more strain going through your glutes. The next thing that we need to do, let me just turn this so I can show you, is make sure, like we have done with the Pilates exercises, that the movement is controlled. So I might be going down slowly, but if this knee is internally rotating, that indicates not the best level of control from the glutes. So keep the knee in line with the toes as they drop down and back, down and back. You could, as their therapist, provide a light push to the outside of the knee so that they have to resist you and push against your hand, or you could use an exercise band to achieve that as well. but that often helps them to realize what it is they're trying to do and which muscles they're trying to activate. So as they come down, you could push lightly. They have to push against your hand to keep that leg in alignment, and back, down and back. So you're avoiding this movement and you're encouraging a nice straight leg. So using an exercise band, I'm using the same one that I used around my knees earlier. I can attach that to a piece of sturdy furniture. Then I can perform some resisted adduction exercises like so. This next exercise is a more advanced adductor exercise, but because FAI often affects young athletic populations, you definitely want some advanced options. So the leg you want to strengthen goes up on a raised surface, like a weights bench here. I'm using the couch obviously, or a chair is also an option. From there, resting on the elbow and forearm, and then from here you want to bring your body up into a position of alignment. Lower down and up. As you could probably tell from that demonstration, that is quite an advanced exercise, so make sure that you use it and select it with the right patients. That brings us to the end of the Pilates and strengthening exercises for hip pain and femoroacetabular impingement. I hope you found those helpful, and I do recommend that you try those exercises before showing them and teaching them to your clients and patients. Thanks for watching. I'll see you in the next video. In this video, we're going to have a look at a flexibility or mobility routine for people with FAI. Now, I'm going to show you some stretches which hopefully should be comfortable and somewhat alleviating. However, it's important that you identify and build a routine that is helpful for each individual client. For example, there may be one of the exercises we do today which causes a bit of discomfort, and you wouldn't want to just do it because it was included in this exercise video. So you need to customize the plan for each individual. Having said that, these stretches have been specifically chosen for this patient population, so there's a high chance that they should be helpful and offer some pain relief or improvements in flexibility. Now, on that note, improvements in flexibility, we should just think about that for a second. We can't improve the limited hip flexion which comes about with femoroacetabular impingement. If there's a bony contact and a buttressing up of those morphologies that we've talked about on this course, the cam, the pincer, or both, then that is an anatomical restriction that we can't force or change or stretch into. So that being said, there's a couple of movements that we need to be careful with when we're doing any stretching, and they are hip flexion was coming up into flexion, adduction, internal rotation, so that would not be a helpful or comfortable position to go into, but also just basic hip flexion with the knee coming up over the chest. That, if it's not restricted, that may be painful, especially into end of range. The next movement to be cautious of with your stretching routine is excessive extension of the hip, so too much hyperextension. It causes the femoral head to glide in the acetabulum, potentially injuring the cartilaginous labrum, which is often injured in people that have a femoroacetabular impingement. So avoid excessive hip extension and also excessive hip flexion. Let's have a look now at what you could do to help alleviate muscle tension, potentially improve some of the ranges of motion, and generally reduce pain around the hip. Number one is the glute stretch. Rather than bringing the knee directly up over the chest, add in some external rotation by bringing the knee out, hold around the ankle and the knee, and stretch in that abducted position. The other leg can be either bent up or down, doesn't really matter too much. What does matter is where they feel the stretch. They should feel a muscular stretch in their glutes, perhaps in the groin, and there should not be any squashing in the groin. If there is squashing in the groin, try and bring the leg further out, but if they still feel discomfort in the groin, then this would not be a suitable exercise for them, and they would just want to move within a pain-free range. So that's the first one, the glute stretch, external rotation, then add your flexion, and then feel the stretch. Holding each stretch for at least a few seconds, and doing your best to try and relax the breathing and try and get the maximal benefit from holding that stretch position. Next, we'll focus on releasing tension in the spine with this simple spinal twist. So with the knees up, feet together, this classic exercise is usually called knee rolling, and it just involves rotation of the spine. You can progress this by bringing the top leg up to extend it so it's a longer lever, and that will give you more leverage to twist through the spine. The next exercise we're going to do is the classic Pilates roll down. We're going to do this from our knees, and this helps to reduce tension in the spinal erector muscles. Now, the modification we're going to make with this is an awareness that going down into closed hip flexion would be uncomfortable for people with femoroacetabular impingement. So let's bring our knees apart to open up our hips, abduct our hips, and that's a good starting point. Start at the neck, let the chin drop down, upper cervical flexion, through the neck, shoulders forwards, rounding through the upper back, rounding through the lower back, hands on the floor, curving, trying to create a C shape with your spine, and then head coming down towards the floor and dropping the bum down like so. If that excessive hip flexion is uncomfortable, then just focus on coming down with spinal flexion and keeping the hips in a lesser degree of flexion. Coming back up, imagine you're stacking one vertebrae on top of the other, through the mid-spine, shoulders back and up into the neck. Once again, head goes heavy, upper cervical flexion, neck flexion, round the shoulders, round the upper back, round the lower back, create that C shape with the spine, hands on the floor and flex down towards the floor with as much hip flexion as is comfortable. Rolling back up from the lumbar, thoracic, shoulders back, head up. That's the classic Pilates roll down with some adaptations to make it more comfortable with people that get a pinch in their hip if they drop down into too much flexion. I'm sure you all know this stretch already, but it's a great way of stretching the front of the thigh without getting the excessive hip extension that you get from doing a lunge position stretch. To finish off with, we'll do a nice hip stretch flow. Start in this position, which is commonly called the 90-90, because your knees are at 90 degrees and your hips are around about 90 degrees as well. So from this starting position, keep your feet on the floor and roll over to the other side, sitting up as far as is comfortable, and then roll onto the other side again. Now, if any of these movements cause discomfort, then as I said at the beginning, make a note of that and don't do that as part of their routine. If they get on with this exercise, it might be one that you want to do at the beginning of the mobility routine as well. So that brings us to the end of this video. Just remember not to do that direct hip flexion, and also to be careful with the hyperextension of the hip, as that can stress the anterior joint. Otherwise, I showed you some stretching techniques that you can do with some adaptations for people with femoroacetabular impingement. Make a note of the ones that they like and that work, but also make a note of the ones which they don't like and that are uncomfortable, so that you can make sure they don't do those stretches as part of their mobility routine. But that may also link to some of the things that they're doing in day-to-day life, which you can have a look at and modify to help reduce their symptoms. Thanks for watching this video. Let's move on to the next one. Massage around the hip and lower back can be appreciated by patients with femoroacetabular impingement, and that's because it can really reduce the pain and muscle tension around this area and rather quickly reduce the symptoms as well. So there's definitely a place for hands-on manual therapy for patients suffering from FAI, as the surrounding musculature, although it may have lost some of its control and coordination and strength, it's often in a state of high tone and high sensitivity, which can be reduced with some simple hands-on or using tools and cups and things like that. So we're going to be doing that. I'm going to show you 6 routines for different muscles around this area, using different things from hands-on skills to some massage tools as well. We'll start with this technique over the glutes. Come above the glutes and just grab around the top of the pelvis there. That's our fixed point. And then we can pull the pelvis up to stabilize, as we then use the base of our palm to come down over the superior glutes. That's a nice technique to do over the glutes, and it may be one that you wish to start on as well. So hooking and stabilizing with my left hand, and then moving down through the glutes with a nice pressured friction over the top of that superior glute tissue. Next, if you stabilize over the back of the pelvis, you can then work into that same area. I'm going to move this arm out of the way because it's in the way of the camera. So a soft fist coming in there, rotating the whole arm, keeping the wrist in that neutral position and not getting a thumb involved, because thumbs are quite delicate and the glute tissue is quite strong and sturdy. So you're going to wear out your thumbs and risk injury if you go and use your thumbs too much around the glutes. You can also approach the glute from the side. With the patient inside lying, you can roll off the back of the greater trochanter and into the fleshy glute tissue there, perhaps coming down a bit lower from the superficial down into the mid area, so you can target the gluteus medius and some of those medial muscular fibers as well. For this, I'm going to use a massage tool. I'm going to use a ISTM tool. This is a rock blade. It's a nice large stainless steel tool, and one of the things that it will do is save my fingers and thumbs. So yes, the thumb is okay for getting into the glutes there, that will work, but it will also not be very favourable on your thumbs. So using this to augment the manual therapy and make things easier for myself. Roll off the back of the greater trochanter to locate the right area, and then I'm going to be doing a scooping action using this upper part here to scoop around initially the superior part of the glutes there, and then come down a little bit lower. So let me show you what we're going to do. Scoop over, stabilise the pelvis with the other hand, and then a scooping, twisting action into the superior glutes. And yes, you're probably looking at this thinking I'm going over the top of the shorts. I often would do that with patients because with the tool, it allows me to work over clothing and still get a very therapeutic and effective treatment, and is often preferred by patients as well. Of course, you can go directly on the skin, that's also an option, but working around the glutes there with this tool is a fantastic way of reducing sensitivity and tension in the glutes, which has a carryover effect of making the hip feel generally looser, less sore and less symptomatic. So I'd usually do this for up to 2 or 3 minutes. That's usually plenty, but you usually get some effects after around 1 minute. Find out with your individual patients where the particular tender points are. So in consulting with Richard, he's got some tender points around here and he's just shown me that. So therefore I can focus my treatment a little bit more around that area, perhaps modulating the pressure as well, adding in a bit of extra pressure if that helps, and also thinking about the speed. A common mistake I see therapists making is they're too fast with their treatments. So by moving slowly, you tend to not stimulate the nervous system quite so much. You can get away with a bit more pressure, and generally it's more therapeutic and less likely to elicit a pain response if you move slowly rather than too quickly. So moving slowly with good depth, focusing a bit more on that area that was reported to be tender up in the superior glute fibers. Continuing on the theme of using massage tools, here I'm going to do some cupping. I'm using a silicone cup. This is a rock pod, and the advantage of this is I can go ahead and place that over the location on the glutes. It was a bit tender around this upper part, wasn't it? So I'll go ahead and place that there. Very simple to use these silicone pods. All you need to do is press the top down to deform them, put them in place, and then let go, and they will reform themselves. And when they reform, they form the vacuum underneath the cup. So that creates a lift. So this is like a reverse deep tissue massage. With deep tissue, of course, you're going in with pressure. Here, we've got negative pressure lifting the soft tissue, and that still gets down into the deeper layers. So not only does it look after your own hands and save your thumbs, but it's also often preferred by the patient because they get this lifting effect rather than excessive pressure down through. We can add to that lifting by lifting the pod away from the body to further lift the soft tissue, and we can also mobilize the soft tissue by keeping the cup in place but mobilizing the skin and pulling the musculature underneath. And that can work really well, really therapeutic and very easy to apply. We'd only leave the cup on for a short duration, up to 2 minutes, so we don't leave any excessive marking. Easy to remove, and then relocate and continue the treatment with the pod in a slightly different position. You could add in a bit of active release by passively assisting the hip up into some flexion, and at the same time pulling the soft tissue in the opposite direction and getting some extra tissue stretch as you do that. So this is a shearing technique. I pull the cup this way and flex the hip this way, so it tightens up the soft tissue, and we can add in some mobilization there as well. And of course, we're being mindful that hip flexion can be uncomfortable, so we won't flex too far, or we'll externally rotate and abduct and bring the hip up into this position here. You've probably got a massage gun somewhere in your clinic as well, and these can be useful for working around the glutes. The typically larger glute tissue lends itself to being a good contact point for the vibrational percussion guns. Just be careful you're not using one that's too powerful or too vigorous, as this can cause some discomfort. Here I'm just using a small massage gun called the Flow Nano, and this just provides some gentle stimulus over the glutes. When you're using these tools, I would recommend angling them to at least 45 degrees rather than having them direct and perpendicular into the soft tissue. That provides quite a significant percussion, whereas the angulation is slightly gentler on the soft tissue and often preferred by the patients. You don't need to do this for very long, 10 seconds on any given area. So around this area here, up to a minute would probably be plenty, and after that you may start to get some unnecessary soft tissue irritation, and sometimes you can get some reported itching from the area as the vibrational percussion has stimulated the nerves to a degree that it's caused a bit of itching in the soft tissue, so avoid that. The next technique is a classic ball on the wall. So here we need to get the ball against the wall and then into the upper glutes. And if you have a slight bend in the knees as well, that can also help, because then bending and straightening the knees allows the ball to roll up and down, and a slight rotation of the body allows the ball to roll across horizontally. Of course, you can place the ball in the correct areas to target those tender points, and you want to place the ball over the softer, fleshy, muscular areas, typically of the upper glute fibers. And then rolling around that ball on the wall is an excellent self-massage treatment that you can have a go at or show your clients. You can also use a foam roller to apply some pressure over the glutes and get down on the floor and do some simple self-massage techniques over the glutes, as Richard is demonstrating here, sitting on the roller, rolling to the side to target the different glute fibers, and then also rolling up and down the roller a little bit as well. If you go into this position with the leg crossed over, this also puts the glute in a slight stretch and helps you to target those glute fibers with a bit more pressure as you've got more weight going down through the roller. Once again, these techniques usually only take a couple of minutes to be effective. You can do them more if you do find them effective, but it's probably better to do them little and often rather than to spend too long on any given session. Next, we'll look at the TFL muscle, the tensor fasciae lata, and I've put a piece of tape on here to roughly represent where that muscle is. So it's just on the side, slightly to the front of the hip. I'll pop a picture on the screen here so you can see the location and anatomy of the muscle. So to target this muscle, you're probably going to want to use your fingers and thumbs to do some trigger pointing and reduce the sensitivity and tension. But once again, watch out, don't overuse your thumbs. You may wish to use a massage tool, many of which exist. Here I'm going to use the Rock Blade Mohawk, which is a bit like my surrogate thumb, and I can use that to apply some pressure down into the TFL at different points through the length of the muscle, holding each point for around about 10 seconds. It's a little bit difficult to capture this on camera for you, but with the addition of the tape showing roughly where the muscle is and the ball there, you can see that some trigger pointing could be achieved using a simple massage ball. You can also self-massage the TFL using a roller. With a roller, you don't always have to roll up and down, although that's a typical way to use them. You can also roll across the roller horizontally, as Richard is demonstrating here, to apply and release the pressure on and off the TFL. Next, we're going to look at some techniques for the hip flexors and perhaps consider the psoas as well. The first technique I'm going to show you is a type of dermoneuromodulation technique, and we're going to use one of these silicone sheets here. The reason we're using that is it sticks nicely to the skin and allows us to get more of a purchase on the skin and the underlying soft tissue. We're going to use that to create a superficial soft tissue drag on the lower abdomen and anterior pelvis there, whilst Richard then straightens his leg out by sliding his leg out over the couch into extension. You'll see the other side is held up into flexion to make sure that the whole pelvis doesn't just tilt and the stretch is focused on the anterior hip here. So using this silicone sheet, I'll place that over the anterior pelvis. That gives me a nice bit of grip there. I'll then pull the soft tissue up superficially so we've got some shearing. And that silicone's gripping nicely on the skin, so I have got more pull and more purchase. Then I'll ask Richard to straighten his leg, and the combination of the pull, the active straightening, and the locking of the other hip to hold the pelvis in position may bring about some light stretching over the anterior hip. Okay, and back again. And I'd usually do 2 or 3 repetitions. So apply the superficial glide, instruct the patient to straighten their leg and hold the other hip up to keep the pelvis stable. When you're confident you've done enough work around the hip, you can continue to work down over the thigh as well. You may also wish to continue using some massage tools which can augment your treatment and really help to make things easier for you and potentially speed up the results that you're trying to achieve. Once again here I'm using the rock blade up over the thigh. You can teach clients to massage their quads using a rolling pin or a more purposeful massage rolling pin such as the trigger point one we're using here. These are brilliant for just applying self-massage techniques, especially to the lower limb, and this demonstration over the quads, I can assure you, is very therapeutic and really helps. Even if you don't have any muscle tension or problems, it just feels really nice, like a good massage. Don't forget to target the adductor muscles as well, as these can often be a little bit tight and sensitive in people with femoroacetabular impingement. So make sure you spend a bit of time working on the adductor muscles. This sideline position is a great position to work on the adductors, and in addition to using your hands, I also find the rock pods are very effective around the adductors. You can simply pop one on, mobilize the soft tissue for around about 60 seconds, take it off and then relocate it further down the adductors and continue like so. 1 minute in each place. For part 6, we're working on the lower back. So you could do this technique with the patient seated in a flexed position. It's nice and easy for you to use the base of your palm using the thenar and hypothenar eminence there as our contact points. You can then straighten your arm and then simply use gravity to help you slowly flow down over the erector spinae, and then repeat that on the other side. Here's some clips on the screen now of some lower back techniques from our other course, the Advanced Massage for Back Pain. So have a watch of these clips to give you some ideas of some soft tissue techniques for the lower back. Part 7, Surgery. Is surgery required? Surgery for femoroacetabular impingement is usually done via a small incision and a bone shaving procedure. It usually involves a secondary procedure to debride or repair the joint's fibrocartilage labrum, and the joint capsule is also affected and needs to be repaired. The key question for this video is, should you have surgery for femoroacetabular impingement? Deciding on surgery for FAI depends on several factors, which we're going to look at in this video to help you or your patient decide what might be the best option. If symptoms are mild and manageable with physical therapy, activity modification and medications, then surgery may not be necessary. If significant pain and limited mobility affect daily life, then this would make surgery a much more viable option. You should also consider the response to non-surgical treatments, like physical therapy, for example. So if non-surgical treatments like physical therapy provide relief, then surgery might not be needed. But if the symptoms do persist despite the best efforts of physical therapy with activity modification, for example, then this would indicate the need for surgery. Then consider the impact on quality of life. If there are significant limitations in daily activity or physical activities, this might warrant surgery. If there's minimal interference with activity modifications, you can get on with your normal day-to-day activities, then this may favour a non-surgical approach. Then consider age and activity level. The younger, active individuals may actually benefit more from surgery to maintain their activity levels. Without treatment, the symptoms of FAI syndrome will probably worsen over time. The long-term outlook for patients with FAI is currently unknown. However, it is likely that a CAM morphology is associated with hip osteoarthritis. It is currently unknown whether the treatment for FAI syndrome prevents the hip osteoarthritis. It's interesting to note that hip arthroscopy can increase squat depth within 8 to 32 months post-operatively and restore it to a depth resembling that of healthy controls. So there's certainly an argument for having a surgical procedure in order to protect the joint, although this is not clear from the current research that's available. Older individuals or those less active might prefer conservative treatment without surgery if symptoms are tolerable. You should also consider the risks and benefits of surgery. The benefits of surgery, of course, can be pain relief, improved function, and preventing further damage or delaying future problems. The risks, there's always risks with surgery. These include infection, blood clots, and anesthesia complications. Then there's the type of surgery. Most surgery is arthroscopic, minimally invasive surgery, where there's a faster recovery and fewer complications. But sometimes open surgery may be needed for severe cases, and of course this has a longer recovery period. So in summary, surgery for femoroacetabular impingement can be beneficial for severe symptoms, those that are unresponsive to non-surgical treatments, and I would recommend consulting with a specialist to provide personalised guidance, and always consider getting more than one professional opinion if you're considering surgery for this condition. This brings us to the end of the course. Hopefully you feel confident and ready to help your next client or patient suffering from femoroacetabular impingement. In many cases, you can significantly help people just by listening and offering some sensible advice on activity modification. If you're a manual therapist, such as a massage therapist or body worker, then the assessment and advice could be incorporated with your hands-on treatment. So don't forget, releasing muscle tension in the hip and lower back musculature can really help to reduce pain and the symptoms. What you now have to offer can really make a huge difference to people's quality of life if they have FAI. If you are required to work with a client who has had surgery for FAI, I would recommend this paper.